The goal of this video lecture is to go over the diagnostic criteria for the different psychotic disorders and to discuss how we distinguish these psychotic disorders from one another. So I'm going to talk a little bit about the diagnostic criteria for the psychotic disorders. And what we're going to do is we're going to start with schizophrenia as our prototypical psychotic disorders and then define the other psychotic disorders by comparing their diagnostic criteria to schizophrenia. Schizophrenia is a psychotic disorder that's characterized by the positive and negative symptoms of the psychotic disorders. So the primary diagnostic criteria for schizophrenia is that an individual needs to have at least two of the following symptoms. So they include the positive symptoms that we talked about, so those might include delusions of various types, hallucinations, disorganized speech, disorganized or catatonic behavior, and it might also include negative symptoms. And all of those negative symptoms are considered one cluster. So you might see catatonic negativism, that would be considered a negative symptom. You might see avolition or alogia or affective flattening. All of those would be considered part of this one group. So you need to have at least two of this set of 5 symptoms. And importantly, at least one of the symptoms needs to be one that is marked with an asterisk. So you need to have the presence of at least delusions, hallucinations, or disorganized speech. So in addition to having the specified number of psychotic symptoms, these symptoms need to be present for at least 1 month. So we call these symptoms active psychotic symptoms. So if a person is actively experiencing delusions, hallucinations, or disorganized speech, if their behavior is disorganized, or if they're experiencing negative symptoms, we would call that a period of active psychosis. And that active psychotic symptom presence needs to be present for at least 1 month. But in addition to the presence of active psychosis for at least a month, there need to have been continuous signs of disturbance for a period of at least 6 months. So there may not have been a full period of 6 months of active psychotic symptoms, but there have been changes to behavior or functioning. So there are changes that are evident in a person's emotional experiences or behavior or cognition or level of functioning that have been evident for at least a 6-month period of time. So the duration criterion has 2 components. You need active psychotic symptoms for a month and noticeable changes for a 6-month period of time. In addition to the number of symptoms and the duration, we also require that the level of functioning in at least one major area has markedly declined from a previously achieved level of functioning. So for example, someone's level of educational attainment or achievement is decreased from what they had previously been attaining. Perhaps their ability to function independently. So you're thinking about someone who has previously achieved a certain level of functioning who's then having a noticeable decline in functioning. So you might have a young adult who has moved out and they're living independently on their own, and then they stop being able to live independently. So maybe they're not able to meet their basic needs for hygiene, they're not feeding themselves on a regular basis, so they need to move back in with their family to be taken care of. That would be evidence that their level of functioning has significantly declined. When we're looking in younger populations, sometimes we might not see that as a significant decline, but it might be a change in trajectory. So what you might see, for example, in late adolescence, is that someone is on a trajectory where they're achieving developmentally normal levels of independence, and then as they start experiencing these psychotic symptoms, that they are not following that same trajectory as would be expected. But in both of these situations, what we're observing is a decline in functioning. So either a decline from a previously achieved level of functioning, or what could be considered a decline because we would assume that they should have achieved a specific level of functioning, but that they're not progressing as would be expected in a developmentally appropriate way. An important thing, not only with schizophrenia, but with all of these psychotic spectrum disorders, is that these symptoms cannot be caused by a medical condition or by the effects of substance use. So for example, we know that cocaine use can lead to some of these psychotic symptoms, for example, delusions and hallucinations. So if these psychotic symptoms can be attributed directly to a medical condition or substance use, we would not give a diagnosis of a psychotic disorder. So that's true for schizophrenia. That's also a criteria for all of the other disorders that we will talk about. So schizophrenia, like I said, we're going to treat this as our prototypical psychotic disorder. So it's characterized by these psychotic symptoms, these positive and negative symptoms. We have a duration of at least a month of active psychosis and 6 months of changes to behavior and a decreased level of functioning. As we move along what we can consider the schizophrenia, the next disorder that we're going to talk about is schizophreniform disorder. And schizophreniform disorder differs from schizophrenia in terms of duration and also in terms of severity. So the primary symptoms of schizophreniform disorder are exactly the same as for schizophrenia. So the same psychotic symptoms and the same requirement for number of symptoms. You need to have at least 2 of the 5 symptoms, and you need to have at least one of those symptoms that was marked with an asterisk. So the first major difference from schizophrenia is that the duration is different. So the duration of changes that you observe in schizophreniform disorder is between 1 and 6 months. So there has been at least 1 month of the presence of psychotic symptoms, but you haven't observed 6 months of continuous changes in behavior. So schizophreniform disorder has a shorter duration than schizophrenia. And another important difference is that a diagnosis of schizophreniform disorder does not require that impaired level of functioning. So it does not require that a person's level of functioning is markedly below what they had previously achieved. So you may see impaired functioning, but that drastic change or decrease in level of functioning is not required for diagnosis. So often schizophreniform disorder is considered a precursor disorder to schizophrenia. And actually in about 2/3 of cases where an individual meets criteria for schizophreniform disorder, they will ultimately meet criteria for full schizophrenia after that 6 months duration criterion has passed. So schizophreniform disorder is considered on the schizophrenia spectrum. It's very closely related to schizophrenia, but it differs in terms of the duration because it is shorter, and it's also different in terms of level of severity because the level of functional impairment is not as high as what's required for a full diagnosis of schizophrenia. As we continue to move down the schizophrenia spectrum, we have another disorder called brief psychotic disorder. So as you might guess from the name of this disorder, one of the primary differences between brief psychotic disorder and the last disorders we talked about is the duration of the symptoms. So for a diagnosis of brief psychotic disorder, the symptoms are similar but slightly different than for schizophrenia. So you need to have the presence of at least 1 psychotic symptom, so you don't need to have 2. These symptoms can include delusions, hallucinations, or disorganized speech. They might also include disorganized or catatonic behavior, but you'll note that they do not include the negative symptoms as a potential criterion for brief psychotic disorder. In addition to the presence of the psychotic symptom, we have a duration criterion. So as you might guess from the name of brief psychotic disorder, the primary characteristic of this disorder is that the psychotic symptoms are present for a brief period of time. So if psychotic symptoms are present for a minimum of at least 1 full day, but a maximum of 1 month, an individual would qualify for a diagnosis of a brief psychotic disorder. If the symptoms continued for longer than a month, then we might consider an alternative diagnosis, for example, schizophreniform disorder. And importantly, after the psychotic symptoms resolve, the individual returns to their previous level of functioning. So we often see brief psychotic disorder occurring in response to some kind of specific majorly stressful life event. This is also relatively common, not common in general, but common relative to other stressors in the immediate postpartum period. So about 1 in 10,000 women will experience a psychotic episode in the 4 weeks following the birth of a child. And these psychotic episodes tend to be limited in duration, so they'll be less than a month. And after that period of psychotic symptoms, the symptoms completely resolve and the individual returns to their normal level of functioning. It is possible for individuals to have recurrent brief psychotic episodes. So an individual who has had an episode of brief psychotic disorder is at increased risk to have subsequent psychotic episodes, sometimes in response to other major stressful life events. A woman who's had a psychotic episode after the birth of one child is at increased risk to have another psychotic episode after subsequent childbirths. But importantly, after each of these episodes, we see a full return to normal functioning. So these are individuals who are having active psychotic symptoms, but the duration of the active psychotic symptoms is constrained. So it's between 1 day and 1 month. So the level of symptoms can be as severe as what we're seeing in schizophrenia or schizophreniform disorder. And the impairment in functioning can be quite severe, but the duration is the primary difference between a brief psychotic disorder and schizophrenia or schizophreniform disorder. Our final disorder on the schizophrenia spectrum is schizotypal personality disorder. And schizotypal personality disorder is characterized by abnormalities in the domains affected by psychosis, so abnormalities in perception, in cognition, in behavior, but these abnormalities are not severe enough to be considered indicative of fully psychotic symptoms, so it's not considered to meet criteria for active psychosis. So we'll talk about personality disorders more at the end of the semester, but personality disorders by definition are pervasive disorders, so these are disorders that affect an individual's experience in a range of contexts across a range of settings, and that are also of long duration. So these are symptoms that need to be evident by late adolescence or early adulthood, and that are stable over time. So these are symptoms that are less severe than we see in schizophrenia and the other psychotic disorders, but that have a long duration. So what do I mean when I say that we have abnormalities in these domains that are not fully psychotic? Well, one thing that you might see are abnormal perceptual experiences that don't rise to the level of severity that they would be considered full hallucinations. So for example, an individual might report that they tend to see shadowy figures out of the corner of their eyes, but they're not fully experiencing visual hallucinations. They're not clearly seeing things that are not there. Another kind of abnormal perceptual experience that a person might have is that they might see things in patterns that other people don't see. So for example, if they're looking at a pattern of fabric or wallpaper, they might see faces that other people don't see. So these are unusual perceptual experiences, but not necessarily full hallucinations. Similarly, you can have unusual beliefs that are not fully delusional. So for example, you might have ideas of reference, and we distinguish these from delusional beliefs called delusions of reference. A delusion of reference would be a delusional belief that neutral things in a person's environment are meant specifically for them. So for example, an individual might be listening to a morning radio show and the host might say something and they believe that this host is speaking specifically to them. So they believe that that message has special meaning for them and was intended for them. So if that is a strong belief, that would be a delusion of reference. An individual with an idea of reference might listen to that radio show and believe that what the host is saying has specific meaning for them or is particularly important for them, but they might not have the fully delusional belief that the host intended this to be a specific message for them. So it's less severe. They have some insight into the fact that perhaps their beliefs could be wrong, the beliefs are less strongly held, they may change more flexibly in response to additional information, but they are still unusual beliefs that share some characteristics with delusions. Similarly, you might hear strange beliefs, or people might express some magical thinking, or an individual might express some paranoid beliefs that are not fully delusional, so not as severe as what you would see with the persecutory delusion, but still some unusual or unrealistic beliefs that a person is being targeted. So again, we're seeing symptoms that are similar to our psychotic symptoms, but not as severe. We might also see strange thoughts or speech that is unusual but not fully disorganized. So a person might be a little bit tangential in their responses, or their responses might be unusual, but not to the level that we consider it indicative of psychosis. Behavior, similarly, might be unusual. So a person might behave in odd ways, they might act unusually, they might have an unusual appearance, so they might dress in a way that's not normal for their culture, they might seem a little bit odd in terms of presentation, but not to the extent that their behavior is grossly disorganized. We might have abnormalities in affect that are less severe than what we see in full psychosis. So we might see inappropriate affect, affect that's not congruent with what a person is experiencing or what they're describing. We might see affective experiences that are constricted, but not as restricted as what we would see with what we would consider flat affect. And we might also see some impairments to relationships. So we might not see the same level of functional impairment that would characterize schizophrenia, but we might see some functional impairments, particularly in the area of relationships. So for example, a lack of close friends or difficulty maintaining interpersonal relationships. So we consider schizotypal personality disorder to be on the schizophrenia spectrum and to be a less severe manifestation of the genetic risk for psychotic disorders. So for example, when we look at families of individuals with schizophrenia, we'll see increased risk both for schizophrenia, but also for schizotypal personality disorder. So it's a disorder that shares characteristics with the psychotic disorders and is of long duration, but that the symptoms are less severe. They share characteristics with psychotic symptoms, but are not fully psychotic, that an individual is not experiencing that full disconnect between their subjective experience and objective reality. Delusional disorder is another of our psychotic disorders that is characterized, as you might guess from the name, by one particular psychotic symptom. So delusional disorder is the diagnosis that we give when an individual has the presence of at least one delusion and the absence of other psychotic symptoms. It is possible that an individual may have limited hallucinations if those hallucinations are clearly related to the delusional theme, and also those hallucinations are not the prominent symptom. So the primary symptom you're noticing are these delusional beliefs. So an example of delusional disorder is the patient that I talked about on Wednesday who presented at the emergency department, who believed that the FBI had implanted things in her body that were recording everything that she listened to. So she had a very strong delusional belief, and she also had a somatic hallucination that went along with that. So she said that she could feel the devices that had been implanted in her body, but the hallucination was not her primary symptom, and she didn't have any hallucinations that were not related to this delusional belief that the FBI was tracking her through these devices. And importantly, she didn't have any other psychotic symptoms. So she didn't have any other hallucinations, her behavior was not disorganized, her speech was not disorganized, she didn't exhibit any negative symptoms. So really her primary problem was this specific fixed delusion. The delusional disorder needs to be present for at least 1 month. And other than the consequences of the delusion, in general, an individual's functioning is not impaired. So for example, I mentioned that this patient had quit her job because she was worried about the consequences of this monitoring, but she wasn't experiencing impairments in other areas. So she was able to maintain her relationships, she was caring for herself fine, she was able to go to the grocery store, she was able to do her laundry. Her primary problem was that she was experiencing these delusional beliefs. Delusional disorder is relatively uncommon compared to the other psychotic disorders, and it can also be very challenging to treat. Because an individual's level of functioning in general is relatively high, it can be very challenging for them to see the delusional belief as a problem and to seek treatment for that specific psychotic symptom. So delusional disorder is a disorder that's characterized by a psychotic symptom, but we've only got one psychotic symptom. So if we think about these psychotic disorders that we've just talked about, we can consider most of them along a spectrum. So at the most severe end of the spectrum, we have schizophrenia, our prototypical psychotic disorder. Less severe in terms of both symptoms and functional impairment related to symptoms and duration is schizophreniform disorder. So we're seeing the same symptoms, but for a shorter period of time, and we're not necessarily seeing functional impairment or a decline in functioning. Even shorter in duration, we're seeing brief psychotic disorder, so we're having the same symptoms, but for between 1 day and 1 month period of time. And then at the least severe end of the spectrum, we have schizotypal personality disorder, where the symptoms are less severe, even though they're persisting for a prolonged period of time. Delusional disorder is not on this spectrum because it's a little bit more unusual, so it doesn't have all of these psychotic symptoms. It's really characterized by that one specific psychotic symptom of the presence of a delusion. In addition to these core psychotic disorders, I want to spend a little bit of time talking about schizoaffective disorder and how we distinguish schizoaffective disorder from other related mood disorders, particularly the mood disorders. So schizoaffective disorder is also a relatively severe psychotic disorder. If we were going to put it on that spectrum that was on the last slide, would be comparable in severity to schizophrenia. And we give a diagnosis of schizoaffective disorder when an individual meets criteria both for schizophrenia and a mood episode simultaneously. So this diagnosis developed because clinicians were noticing that there were individuals whose experiences seemed to be characterized by both psychotic symptoms and mood symptoms that were very closely related. And by closely related, I mean that the majority of time that they experienced psychotic symptoms, they were also experiencing mood symptoms. So those mood symptoms might meet criteria for a major depressive episode, or they might meet criteria for a manic episode, but these are individuals where their psychotic symptoms and their mood symptoms seem very closely related. But the important thing that distinguishes schizoaffective disorder from other possible diagnoses is that there's at least a 2-week period of time in which the psychotic symptoms are present in the absence of mood symptoms. So we're not only seeing psychosis in the context of a mood episode, there are also periods of time when an individual is euthymic and is still experiencing at least 2 weeks of psychotic symptoms. So how might we distinguish schizoaffective disorder from some other potential diagnoses? Well, schizoaffective disorder, remember we could have either type of mood episodes. We could either have depressive type schizoaffective disorder with a major depressive episode, or a bipolar type disorder where we would have symptoms of a manic episode. This would mean that we're seeing symptoms that meet criteria for schizophrenia and our mood episode, that we're seeing mood symptoms for most of the time that a person is experiencing psychotic symptoms, but that we've had at least 2 weeks of psychotic symptoms without the mood symptoms. We could contrast this with an individual where you might give a diagnosis of 2 separate disorders. So you might give a diagnosis of schizophrenia plus a diagnosis of major depression, or you might give a diagnosis of schizophrenia plus bipolar disorder. And typically that would be bipolar disorder type 1, because if an individual is experiencing psychotic symptoms, that automatically means that we're going to consider it mania instead of hypomania. So when might we give this diagnosis as opposed to schizoaffective disorder? Well, this would be appropriate if we are seeing significant periods of time where we have symptoms of mood disorder without psychotic symptoms, or if we are seeing significant periods of time where we have psychotic symptoms without the presence of mood symptoms. So remember, for schizoaffective disorder, for most of the time that an individual is experiencing psychotic symptoms, they also need to be having those mood symptoms. So if we are seeing separate sustained periods of time of psychotic symptoms without mood symptoms, or mood symptoms without psychotic symptoms, we might want to give both diagnoses to capture the fact that these don't seem to be related to one another, but that this is an individual who is having separately significant psychotic symptoms and also significant symptoms of a mood disorder. We have a third option, which we've talked about, which is that we might also give a diagnosis of a mood disorder with psychotic features. So this is what we would consider when we don't have evidence for psychotic symptoms outside the context of a mood episode. So if the only period of time that an individual is experiencing psychotic symptoms is during a mood episode, particularly if their symptoms are mood congruent, then we might consider a diagnosis of a mood disorder, so either a major depressive disorder or bipolar disorder type 1 with the specifier of psychotic features. And what that implies is that these psychotic features are a characteristic of the mood disorder, but that the individual doesn't appear to have a separate psychotic disorder. So if the only time that a person is having psychotic symptoms is during a significant mood episode, that suggests that a diagnosis of schizophrenia or schizoaffective disorder is not as appropriate. So when we're thinking about schizoaffective disorder, we want to distinguish this from our mood disorders with psychotic features, or sometimes we might consider a diagnosis of both a psychotic disorder and a mood disorder. And the most important thing to know about a patient when considering which of these options would be the most appropriate is whether they are having symptoms of psychosis or of a mood disorder independent of the symptoms of the other type of disorder. So do they have psychotic symptoms in the absence of mood symptoms, or do they have mood symptoms in the absence of psychotic symptoms? So that wraps up our overview of the psychotic disorders. We started with schizophrenia and used that as our prototypical psychotic disorder. We also had schizoaffective disorder, which is comparable in terms of severity of symptoms to schizophrenia, but also included those significant mood symptoms. Moving down our schizophrenia spectrum, we have disorders that are characterized by less severe symptoms and shorter duration, going from schizophreniform disorder through brief psychotic disorder through our least severe schizotypal personality disorder. We also had delusional disorder, which shares one feature of the psychotic disorders in terms of the presence of delusional beliefs, but does not share the other psychotic symptoms. So when we start class on Friday, we will start with an activity where we apply this information to think about the differential diagnosis of psychotic disorders. I look forward to seeing you then.